Dominique Metras, welcome.
Thank you.
As you know, we've initiated a project, a history project in ISHLT that focuses on recording archival material that documents the history of the field of heart and lung transplantation, particularly in the early days when things were new and the field was just evolving. And to that end, we're very interested in interviewing people such as yourself who've had a major impact on the development of the field. So we're very grateful that you've joined us here today.
Well, thank you very much. I just want to say that my contribution was modest, was not major, as you say.
Well, I don't know about that. But if we start back with your training and your interest, how you evolved an interest in medicine, I think I understand that your father played a major role in your gravitating toward a career in medicine. Could you tell us a little bit about your father?
Oh, yes. Well, my father was a thoracic surgeon. He died early, at the age of 40. He had a disease because during the war, just after the war, in 1946 and 47, he created the Metras catheter to do bronchograms and to treat people with antibiotics, local antibiotics. That was the beginning of antibiotics. And his catheter were preformed to go to any lobe you wanted. And they were used throughout the world. He was invited everywhere for that. And during that time, he was exposed to X-ray. And finally died 10 years later of leukemia, probably due to this irradiation. Well, my father was an extraordinarily dynamic person. And he started, lung surgery, and even he went to the US very early to watch Dr. Bailey, Dr. Blaylock. He started also some heart surgery. And concerning transplantation, I knew this later because when he died I was 15, so I didn't know him professionally. But then I read what he had written, and he reported at the Academy of Science in France in 1950 his experience on lung transplantation in dogs, and he described a technique that is now used by everybody. He was the person who described the fact of taking a piece of left atrium around all the pulmonary veins, so to anastomose the cuff of atrium. He did this on 20 dogs in 1947, 48. There were 16 operative survivors, one of them surviving 3 weeks. And at this time, there was no immunosuppression. And also in the last dogs, in the 5 last dogs, he also harvested the bronchial artery of the donor and anastomosed it to the subclavian artery of the recipient, thinking that the improvement of vascular supply to the bronchus would improve. Can you imagine? That's in 47.
So this is at a time before the first human kidney transplant was done, years before.
I think so.
Several years before.
Yeah.
How did he do those? How did it happen?
Well, at that time, he had decided that he had to try to do some transplants. And I know my mother told me, because at that time I was very young. He did this in 1947. And that was a real adventure, because he was operating during the day 2 or 3 cases in various hospitals or clinics. And he went to do the transplant on dogs at the laboratory at the Faculty of Medicine at night. But the faculty was closed, and there was a guard. So he came with his team, one anesthesiologist, one surgical help, and my mother. My mother helped him as a scrub nurse, and they had to pay the guard to open the gate of the faculty, and the faculty was closed, so they entered through a window. And they were in the basement where the so-called lab was, and they did the transplant sometimes at night like this. And can you imagine?
I can't imagine. And what equipment, what sorts of things did they use for the surgeries?
Well,
where did they get the equipment?
Well, they got their instruments. They come with their instruments and anesthesiology, everything. Mm-hmm. And the fields, the drapes. My mother took, things they were enveloping my little sister for, how do you call that?
Bed sheets?
Yeah, bed sheets that were sterilizing and using this, just after the war. Not very rich, and they were using this for draping the dogs.
It's extraordinary. It's extraordinary to think about this, and then some years later it became reality. But to be experimenting in the university laboratory in the middle of the night doing transplants.
And I wrote a paper on in the Journal of Thoracic and Transplant, Journal of Heart-Lung Transplantation, about the pioneering work of my father on heart transplant or lung transplant, which is a translation of his report at the Academy of Science in 1950. And Joel Cooper made a comment in this paper saying that it was amazing to realize that 20 years or more before, Metras had seen correctly how to do a lung transplant.
And how to improve it, even, in an area that became quite difficult, didn't it? It's an amazing story.
He was very, very creative. So unfortunately, he died at age 40. I was the first of the family, and he didn't want me to be a doctor because he thought medicine was not having a good evolution in France. So he thought he wanted me to be in the administration or big schools like École Normale Supérieure in France. And all naturally, without anybody pushing me, I started medicine. And then later I discovered what he had done, you see, because I didn't know all that when I started.
It's an amazing thing to discover that your father's been such an innovative, really doing things that were really creative for the future.
Yes.
At that particular moment in time.
Well, I knew that by my mother because he was invited everywhere. At that time, it was rare. In the early 50s,
yes.
He was invited in Japan, in South America, even made a paper at the AATS, which was not frequent by foreign people. He was invited in Russia, and anyway. So I knew my mother had seen the whole world following him. So I knew he was somebody important. But
so did this influence not only your entry into medicine, but into surgery as well, and eventually into transplantation? I mean, it's almost as if you became the personification of some things that he was working on decades before.
No, I'm not sure. When I started my residency, I was in service of pediatric surgery, and one day they told me to operate a hernia of a newborn, not an infant of 3 months. And after 1 hour or 2 hours of struggle, not being able to do it, I thought in myself, well, I'm not going to be a surgeon. So I was thinking of neurology because there was some logic in neurology. I liked it. Because, all with this correspondence between the head and movements, I said, this is intelligent specialty, so I should become a neurologist rather than a surgeon. I'm not capable. So initially, I had not decided to be a surgeon. So it became naturally.
It came gradually then? Gradually,
during my internship and residency, and then at the end, it was thoracic and cardiovascular surgery.
So it's good that you stuck with that pathway, despite your early doubts, perhaps. Earlier in your career, you also did quite a lot of work in Africa, working in tropical diseases, I understand. Could you tell us a bit about that?
Yes, this is before I started transplant, of course. In fact, that's true that after I became a professor in cardiothoracic surgery, I was offered to go and start a program in West Africa. And that was very exciting. It was a country with excellent university relations with France. Even the diploma of doctor in medicine, passed in this country was valuable for France. So it was, interesting. And there were many French doctors working at that place in the Faculty of Medicine. So we started an Institute of Cardiology. The goal being that we train people locally. We start a unit working properly to do cardiac surgery. One of the reasons was that there were a lot of cardiac disease. People did not know that, really, in tropical countries. And when patients needed surgery, either they died or they were sent to France. And so this was very expensive. So they thought it might be maybe not cheaper, but less expensive to organize it locally. So I stayed 8 years in the Ivory Coast. But then our center, you know, we started from zero. Well, in my career, I had a lot of chance, I was very lucky, I think, because I had to start things from zero, which is very exciting.
It's great opportunities.
Yeah, I was very lucky to do that. So we had to start from nothing. I came in the Ivory Coast with a perfusionist, a nurse of intensive care unit that came with me, and they started training people. And when I came back in Marseille, we were doing currently open heart surgery and lung surgery.
And what years was it that you were in
that was from 1976 to 84.
And compared to when you left and when you began that program, what kinds of things were you mostly involved with in introducing?
Well, first of all, I was very proud that without me, they could do the surgery also. That was my best achievement.
So a good teacher, obviously.
Yeah. Well, I don't know, but at least a good helper.
But the kinds of diseases that you were
Well,
treating?
we had mostly rheumatic heart disease, congenital heart disease, and also the endomyocardial fibrosis. We described a lot of things on this disease. We wrote papers. By the way, my first presentation I did at the ATS meeting, I was very impressed, in 1981 in Washington, just the day after the Pope was shot.
Oh.
I remember. We arrived in Washington, the newspaper, Pope is shot. And then I had my paper at that time. So the endomyocardial fibrosis is a very special disease. I think we did some improvement in what had been described as surgery, and I had a big experience.
In that part of the world at that time then, children with congenital heart disease presumably would just perish. And there
probably, most of them, yeah.
Couldn't have been many that were sent to France.
Yes, absolutely.
And what's it like today in
Well, unfortunately, in the Ivory Coast, they have had political problems like civil war. And the economic situation has had a consequence on the function of this institution, which is now starting again to function. But for some time, they went down after I left.
So after you came back from Africa, you came back to Marseille in
1984. October 84.
1984. And that's when you really began to work towards development of a transplant program.
Yes.
And could you tell us a little bit about how that started?
Yes, it started, in fact, during my residency, there was a heart transplant in Marseille, the first one in 1968 by Professor Henry and his team. And this was one of the first in France. And the patient was a figure, because he survived 18 years, so he was a figure about transplant, you see, about the possible success of transplant. He was very lucky at that time to survive 18 years. Anyway, after that, since 1968, there had been no more transplant in Marseille. So I started heart transplant in 85, in December 85.
Can you tell us about that first case?
Yes. First of all, I had to I was in a pediatric hospital, and I decided I was pushed by people to start transplant because transplant was not done in Marseille. So I organized the team of anesthesiologists, of pathologists, of nurses, etc., to be prepared to the transplant. We went to Paris to see how Professor Cabrol was dealing with the immunosuppression, all the organization, the pathology after the biopsies. By the way, in the past I had seen already transplants in the US. I was visiting Norman Shumway, but that was long ago. Anyway, so we decided to do the transplant, but this was in a pediatric hospital. And so I had to ask the chief of surgery, would you allow me to do an adult case in the pediatric hospital? They were very happy because it was a transplant, so they say, of course. So I asked the anesthesiologist, would you agree to put asleep an adult to do a transplant? Everybody agreed, so we prepared. And then one day I came to the cardiologist of the hospital. I said, well, there has been no transplant for many years, but now I'm going to start. We are ready. And so we started like this.
And what the first patient that was transplanted then?
Well, the first patient, he was coming from a hospital in Aix-en-Provence, a very famous city at 30 kilometers from Marseille. So I was called by the chief of cardiology of this hospital. I had visited all the cardiologists of the area, of the province, to tell them I was going to start transplant. So if they had patients, candidates for transplant, they would call me. So he called me, there was a patient. Well, I had trained in the laboratory on dogs, also in the lab with the cadavers. We had organized the technique, etc. And so I went to see this man. I told him, look, you need a transplant. I have never done a transplant myself, but I know how to do it. We have been prepared. We have seen various centers. We are trained. We know how to do it, but I tell you, I've never done one. Yeah. He said, no problem. I trust you.
That's putting a lot on the table, isn't it?
Yeah. And finally, during the night of the 16th of December of 1985, I did my first heart transplant. And then after that, we had 1, 2, 3, 4 more start our program. And then subsequently, the year after, we started to do a pediatric heart transplant.
So going back to December 1985 then, with this gentleman who had put all of his trust in you, what was it? Tell us about that night.
Well, that night, first of all, he had some pericarditis before, so there were adhesions. Just to remove the heart was, for the first time, was not easy for me. And at that moment, when I saw the chest empty, the pericardial cavity empty, I thought, what am I doing? Because I was, in an unknown situation. I said, what am I doing? Because the cardiologist, just before we started the operation, he knew that there was, he told me, you take a big risk, but you will win. He told me, you take a big risk. I said, well,
so you had support from your colleagues then.
Sort of support when they tell you, you have the risk.
But you'll win.
Yeah.
And your team, the preparations that you had done, and you'd got everybody all ready and all prepared.
Perfect.
And
Very good. Very good.
And it worked
people.
as well as you had expected.
Yes, the patient was extubated 3 or 4 hours after the transplant. No, he worked very well. He survived 16 years, the first.
And finding a donor for that first transplant?
Well, in fact, donors were not the problem, because in Marseille, there was a very active center of donor harvesting, because they were doing kidney transplant, not yet liver, but kidney transplant, basically. So they were organized to harvest organs. And the chief of this service was very happy that somebody would start a heart program, because what happened is that surgeons from other towns came to take the hearts of the donors of Marseille. So he was satisfied that this program started in Marseille.
And how many, at that point in time, how many programs were there in France? How many transplant programs were there?
I cannot tell you, I don't know exactly. Not many. But what was, what was exciting at that time is that, well, not exciting, is that you didn't need to have an authorization of the Minister of Health. If you wanted to start a program of transplant, you decided to do it. Whether now, to start a program of transplant, you have to pass through, a lot of administration, a lot of, charts, inquiries, bureaucracy. Now, I decided to do it, and I could do it.
And so the first, so that was the first one in December 1985, and how quickly did the program grow? How quickly did it take off?
Well, it was, considering Marseille is not an enormous, center. At one moment, we did 2 or 3 years after, I did 25 in a year. 25
in one year, just a few years later.
Oh, yes, 2 or 3 years after. The first year I did 8, 85, and if you count the December 85 and 86, we did 8, then 15, then 20, 26.
So by this time, your team is needing to have grown as well. By the time you're doing 25 a year?
No, we were few people.
But
very few people.
But dedicated to transplant.
Yes, few people. For example, I had always to find somebody to assist me to harvest the organ. It was coming from another unit before my unit grew. That I had other people working with me. But it happened 2 or 3 times that I went to harvest myself in another hospital of Marseille, and bring back in my car, with policemen in front of my car, coming to the hospital with the heart, and then transplant it.
In your own car?
This was, now it's not happening like that, of course,
No.
Can you imagine these times?
But these times where if you didn't have the personal commitment to moving it forward,
exactly,
it just wouldn't have happened.
Absolutely.
So then you began to do pediatric heart transplantation in what year?
Yes, or the year after. But first of all, when I say pediatric, it was a 14-year-old, young guy. Then 2 years after, I did a pediatric of 12 months, and then we have progressively done more and more pediatric cases in our group.
And so you continue to do both adult and pediatric cases in the group?
Yes, we've done that for years. Mm-hmm. But in fact, now I'm retired. Yes. It's my successors who continued and developed the program, because they are very good at putting artificial ventricles, etc., for pediatric.
The pediatric transplant program grew alongside the adult program, and then after some time you also began to do heart-lung transplant,
yes.
I believe.
Before that, I just wanted to mention that we in 1987 we used our first thoracic pumps on a couple of patients.
In 1987?
Yeah.
So this was quite early in
yes,
the experience.
we did this with the help of a team coming from Switzerland. At that time, Professor Charlie Hahn, mm-hmm. you may know him, had developed a program of assistance. They came and helped you to put the thoracic ventricles. So I did this a couple of times in '87. And by the way, the second is still alive, and she had a postpartum cardiomyopathy, and after that she was transplanted, and had 2 children more after that.
That's extraordinary.
She absolutely wanted to have a child. So with my co-worker, who is now the chief, we investigated in the literature if somebody having had a postpartum cardiomyopathy could have another cardiomyopathy if she was pregnant again after transplant. As nobody could answer, she decided that she wanted a child.
And she had 2 more successful pregnancies after her transplant.
Mm-hmm. And she's still alive.
That's a wonderful story.
Yes, you told about the heart-lung transplant.
So heart-lung transplants.
Yes. Well, then I thought, after having started heart transplant, that I had to do more. So I decided to have to start heart-lung transplant. So we trained in the lab, and we were ready to do heart-lung transplant. And so in 1987, I did my first heart-lung transplant. Now, for me, it's very memorable because this patient has an Eisenmenger syndrome, so with a lot of collateral circulation. And I did not realize that very much at the time. I knew he had, of course, but I did not realize the potential for hemorrhage of that. So I did the heart-lung transplant by median sternotomy, and the heart-lung harvested by one of my colleagues, Professor Noirclair. I will say something about him later on about lungs. Did the harvesting. The heart resumed perfectly well, the lungs also, but the patient was bleeding. And so we left the chest open. We do this for some time, and we treated. I was reluctant to go again on bypass to try to do hemostasis posteriorly in the mediastinum. So as it was functioning all right, he was bleeding a lot, like 600 cc's an hour. But we were treating this on the cell saver, and he stayed in the operating theater for 2 days.
For 2 days?
2 days, with the chest open. And we're treating, and progressively the bleeding decreased. And on the 3rd day, we closed the chest, and he went to the intensive care unit. And he lived 3 years after that. But then he started smoking, because he had never smoked in his life. And he deteriorated his lung and died after 3 years.
Well, that's a bit of a tragedy, isn't it?
But this 3 days, mind you, it was something incredible. I had to, during these 3 days, waiting for the bleeding to stop, I went out of the hospital.
And he's still in the operating room?
Yeah, but my co-workers were,
yes.
He was still there.
Yeah.
Well, and the cell saver treated 300 liters altogether.
Oh my goodness.
Can you imagine?
That's a colossal case then, isn't it?
Absolutely.
So this was your first heart-lung transplant?
Absolutely, first.
So everything afterward was easier?
No, not at all. No, heart transplant, we had several failures because of patients that were probably contraindicated by present, by present conditions.
But it's interesting, that concept that in the 80s, I think, sometimes the boundaries weren't always clear, were they, about what today we might consider a definite contraindication. For example, in children with congenital heart disease, complex malformations, dextrocardia, some of the heterotaxy syndromes, they're very complicated. And yet, if the surgeons didn't push forward and attempt to transplant some of these children, the size would have probably not gone as small as now it has, and the complexity of the lesions as well, would you say?
Yes, I think so. Well, you say that I think it's something which is, in many fields of surgery is true, that you have to push the boundaries. Otherwise, but pushing the boundaries, of course, sometimes is paid, by the death of patients.
Mm-hmm. Pushing the field forward.
Yeah.
I think you're right. Sometimes these decisions that are very difficult when you have a patient who has no future and it has a compelling patient population. Nonetheless, it's not easy to be the one performing the transplant.
Absolutely.
The immunosuppression that was used in those early days? Well,
we started with triple immunosuppression, with steroids, with steroids and azathioprine, and of course thymoglobulin for the induction, and we had also the immunosuppression with the treatment that started in 1982, I think, no, the cyclosporine.
Yes, that's right.
Well, this is why we could start. In fact, in France, when you look at the number of transplants done in France, It's probably the same throughout the world, but in 1967 and 68 there was, about 50 transplants done. But then progressively zero. Only Professor Cabral was doing some transplant. And then after 82, 83, 84, then it started again to increase. I guess it was the same in the US.
I think so. I mean, it really, the availability of effective immunosuppression really transformed the field, didn't it? Really saved the field, allowing resurrection of it, in fact.
But before starting the heart-lung transplant, I went to Pittsburgh because I knew there were, it's a very, very strong team about that. So, and Dr. Bartley Griffith, who was here this morning, I know, was there, and I know him quite well. And I had the opportunity to attend a transplantation, and that was very spectacular, with the ex vivo, donor organs at that time.
Mm-hmm. Tell us about that.
I was in the room. I think Dr. Griffith was here. Dr. Hardesty was the other surgeon, and they came in the operating room with a box, plastic. The walls were transparent, a plastic box. I don't know. On a roller, and the inside, the lungs were breathing and the heart beating. We could see this entering the room. It was in fact to have the shortest ischemia as possible.
Yes.
It was impressive.
And when was this?
In 1987. At that time, I had no camera and no iPhone to be able to film that, but it was really spectacular, impressive. Like a Frankenstein movie. You see.
Exactly. It really is, isn't it? So after beginning heart-lung transplantation then, eventually you went on and again brought the procedure of lung transplantation into the clinic in Marseille.
Yes, exactly. In fact, during my residency in the years 67, 68, there was a laboratory of experimental surgery held by Professor Noirclair, who was a thoracic surgeon, and we were doing lung transplant in dogs. I don't know exactly the goal of these transplants, but probably survival, and I don't know exactly. At that time, even these, immunosuppression was not clear. Anyway, I did a lot of lung transplant in the lab with him at that time. And we knew that in Toronto, Dr. Joel Cooper and Patterson had done a bilateral lung transplant, or not bilateral, but double lung transplant instead of heart lung for cystic fibrosis. And in fact, it was logical because these people had normal hearts.
Yes.
So as the donors of the heart-lung donors were rare, we thought we should start a lung transplant program, and we did the first pediatric double lung transplant for cystic fibrosis in 1988.
In 1988?
Mm-hmm. Double lung, en bloc. And then subsequently, of course, we changed to bilateral single lung transplant, but for some time we did 10 to 12 en bloc cases.
And for cystic fibrosis at the time, that was still considered quite a difficult diagnosis for lung transplantation.
Yes, absolutely. Well, at that time, if I remember well, at that time, the contraindications of transplant were infections. So it was, paradoxical to transplant a disease that had basically infection of the lung. But it had been shown, I think, by Mr. Magdi Yacoub, who did the first one in 1984, that it was possible. And also in Papworth, they had shown that transplanting people of the lungs with infection or without infection had the same result. So we were pushed to do this kind of operation.
So can you tell us about that patient and that operation?
Yes, well, this operation, I can tell you, I wanted to tell you that to do transplant is very, innovative, as you said. Sometimes it's exciting to be in a new field, but there are inconveniences on the family life. This is true because often I had to leave my family, and I was supposed to go to ski with the family, with the kids and my wife, and I had to cancel everything. And you know, the trip was cancelled. And on this this happened very often. And I know that a family life can be, you know, challenged sometimes. Anyway, well, for this first transplant, you know, I was in Chartres, close to Paris, at the weddings of the daughter of a very good friend of us. And they called me. They called me during the ceremony. Well, there is a donor for this girl who has cystic fibrosis. It was a very stable donor. They thought he might survive, you know, until I come back. So you have to come back to do the transplant. So it was difficult to decide that. I had to, you know, to travel. I went to Paris, take a plane, and come back to Marseille to do the transplant. So this is an impact on our family life, I must say. My wife was not very happy to leave the friends and the weddings. Anyway, this is the, you know, the back aspect.
It's the reality, though.
It's the reality. It's the reality.
Because they're never done in the daytime. They're always done in some inconvenient time.
So we did. I came back and did to Marseille. We did this transplant again with Professor Noirclair, and we did the first en bloc double lung transplant. And this patient is still alive.
Is still alive today?
Mm-hmm. Well, she has some problems of bronchiolitis obliterans, chronic, but she's alive. It's 24 years. Oh, my second heart transplant in January '86 is still alive.
It's still alive today.
Yeah? 26 years later.
26 years later. So the first lung transplant then, and this was a young girl with cystic fibrosis.
Yes.
This was a pediatric.
Yes, she was 16.
Yes.
And then we did patients down to 5 years. But the program of pediatric lung transplantation decreased progressively because the age limit of these pediatric transplants was 18. And as the improvement of treatment of cystic fibrosis was great, progressively they survived until the adult age. Mm-hmm. So now we do, in our program, we do 2 or 3 years.
Fewer children.
Fewer children in lung transplantation.
And more adults. What about the heart?
Adults is another service. It's another program that has developed.
And the heart transplants in infants, how have you seen that change over the years?
Well, it has changed. The main change is that patients have been assisted by transportable ECMO support. So now we have a system of, you know, we can go with a helicopter when there is an emergency, heart arrest in a child with cardiomyopathy, and we put an ECMO, we bring him back home, and then, so this is a major change. And then, after some time of ECMO, we put a ventricle, LVAD or BiVAD, a biventricular assist device, before transplant. We had done this in the past, but you know, now it's very common to do transplant after ECMO support.
The VAD, the whole VAD field, particularly for pediatrics, has really changed our decision-making processes about transplantation, I think, as this option really allows you to do less urgent transplants.
Yes, absolutely. Well, the concept of urgency in transplant has changed a lot since now there are these artificial ventricles, and then the patient are no more urgent.
So generally, they're in better shape when they go into transplant.
Yes, certainly. Despite the fact, you know, they have a ventricle, which is not always quite easy to manage. Some people die of the complications during the ventricular assistance, but nevertheless, it has changed. The condition has changed.
It's changed a lot, hasn't it?
A lot,
the field
yes.
has changed.
Well, in adult heart transplant also.
Yes,
I think.
absolutely.
Practically most transplants now are done after a period of assistance, which was not the case when I started.
Which was not the case, no. That's really changed a lot. Just a few more questions about another aspect of your career. You've done a lot of humanitarian work in other countries, I believe. Can you tell us a little bit about that?
Yes, well, this has nothing to see with transplant, of course, but yes, I've done a humanitarian surgery since, you know, humanitarian surgery is somehow controversial because there is one aspect which is go with a team in a country where there is no heart surgery, do surgery, and go back home. Well, this was considered by my mentor is Dr. Castañeda. I was trained and inspired very much by Aldo Castañeda. He calls it the medical safari. You see?
Yes.
Well, this is a concept which is controversial because is it good to go in a country, operate some patients and go away and leave the situation without any more development? This is not good. Well, it has some good for the kids that are operated, but does not make much progress for the situation.
No, it doesn't change the situation.
Now, what is ideal is the fact of staying in a place and, you know, making a center like we did in the Ivory Coast, but then you depend upon political situation, local evolution, which is you can change. Now there are associations that try at the same time to perform you know, cases, but to train local teams that you know, can operate even if we are not here. This is what should be done. And I've done this with various non-governmental organizations like La Chaîne de l'Espoir. So I've gone in various countries, like in Nicaragua, in your continent, in Nicaragua, with the organization which is called the Surgeons of Hope. The better name would be Surgery of Hope.
Yes.
But nevertheless, Surgeons of Hope. And then also in Africa, in Mozambique, in Cameroon. And I've been in Iraq, in Baghdad, during the embargo, during the time of Saddam, before the Second War. I've been 5 times to operate in the Saddam Center for Cardiac Surgery. It was an agreement with the Ministry of Health of Iraq and French, and we went to do some humanitarian pediatric surgery, but in a center that was doing surgery. And more recently, I go regularly in Palestine. I go in Jerusalem, East Jerusalem, the Palestinian territory, theoretically, where there is a hospital, the Palestinian hospital. And there is a program where several surgeons come from various countries to try to develop a program, a Palestinian program of pediatric heart surgery.
So this will change, I mean, this has a greater aim than those specific individuals, but actually of establishing a program that could potentially be self-sustaining and bring lasting impact to the...
This is what is hoped.
Yes.
Well, in Mozambique, for example, we go in a place where there is a center that works well, Instituto do Coração, which is working well with local surgeons that can perform surgery, but when we come, we do more complex cases. So we train them at the same time.
Yes, yeah. When you look at the years that have passed since you were training and the evolution that you've seen and the changes in the field, particularly relating to mechanical support and transplantation, what do you look at as the next things to come, and what do you think the young surgeons training today will see in the continued evolution of the field?
I don't know. The dream you see, well, there are 2 dreams in my view, or maybe 3 dreams. Well, one, the closest, I hope, is that immunosuppression will become very simple, no toxic, simple to take, and have permanent, excellent results without inconvenience. This might occur, I don't know. The second is, well, if we don't have enough donors, because we don't wish to have donors, in fact, you know, to have donors is to have people who die, you know, accidentally. Shall we have artificial organs? Well, I don't know. I'm not sure we will reach that point of artificial organs, but probably. But I won't be alive, I'm sure. So I will know. I don't know about it. The third is the animal, you know, the animal.
Xenotransplantation.
Xenotransplantation. I think it's xenotransplantation. Apparently, is no more much a problem of compatibility or immunosuppression. It's most a problem of transmitting virus. If it is, I don't know if I'm still, you know, up to date. But at one moment there was a decision not to do any, you know, animal transplants because of this problem.
Because of the fear
transmission,
yes, the fear
transmission of virus.
As you correctly point out, the fear of passage of porcine endogenous retroviruses really didn't have a major impact on slowing down progress in xenotransplantation. But now the years since then, and they've been really worked out that the risk is actually very low.
Is it?
It's interesting to think whether the momentum of that will ever come back, because it was talked about a lot, I suspect, when,
yes, sure.
when you were starting transplant.
Oh, yes, of course. We were, I remember, you know, Baby Faye,
yes.
by Loma Linda, but Leonard Bailey, whom I know well. And also, well, they did one in, I think Dr. Starzl did a porcine temporary liver transplant for 24 hours in an emergency case in Pittsburgh, if I remember well. No, I remember a very funny sentence not funny, humoristic sentence of Dr. Norman Shumway in a meeting. He was saying that xenograft is the future of heart transplant and will always be. Which obviously didn't believe in it.
No, and here it is some 30 years later, and
it's the same situation.
It's wonderful to think about the changes in the field over the years, and we look forward to new pathways. And I think, as we've discussed, the mechanical support, both in what we've seen, the evolution in both heart and pulmonary support, seems to me to be still a pathway that's moving forward with great dynamic kinetics, really. Perhaps that's where surgeons and those of us who take care of patients with end-stage heart and lung disease will see the most developments in the next few years. What do you think?
I think so, yeah. Well, just before finishing, I don't know where we are in this interview, but I want to say that you know, you interview people, but in fact it's teams that should be interviewed, because you know, a man alone can do nothing, and the work, the amount of work and dedication of everybody in transplant is absolutely fantastic. You know, all these people working as a big net, you know, 24 hours a day throughout the year to make this possible is absolutely fantastic. Don't you think so?
I agree completely. And you wonder, there's something about transplantation that captures the imagination and dedication in a way that's quite different, I think. And you're right, it is the minute attention to detail of everybody on board, of every member of the team, that results in these programs where you have superior results year after year, as we've seen in Marseille over the years.
And also, I want to say something about the donors, because, you know, donating an organ is the most extraordinary gift, you know, a human being can do. And I said always this to the patients I transplanted. I told them, You know, you had the most incredible gift possible. Another human being gave you an organ, so you have to respect it. So don't smoke, take your treatment, and respect the, you know, all the prescriptions, etc., because you have to respect this most incredible gift. And this is, you know, we don't think enough about the donors, probably.
Well, I think that's true. I think that's very true. And in fact, you're right. It's not only the recipient teams and the dedication to that makes a difference, but the we're completely dependent on an altruistic gift for the whole field to work at all. And maybe we don't emphasize that quite enough with our families and as we think back on things. I agree with you completely. I mean, when you think back, and as we've had a chance to talk with people who've been in transplantation for several decades now, it's still extraordinary to me that it works at all, and that someone had the imagination and the creative thought to say that if we, for the babies, for example, that you take this tiny heart and move it from here to there, and after some hours, implant it and expect that it will begin to pump again, and it will begin to work again, and it will work for 20 years. It's an extraordinary thing, isn't it? It's been a pleasure chatting with you. I very much appreciate you sharing your reminiscences.
Thank you very much.
Thanks.
But I want to say again that what I've done is very, very little, just a little drop in the big ocean.
An important drop. Thank you very much, Dominique.
Thank you.